1982 in Hawaii, the Navy used to handle a lot of the treatments, diving casualty treatments, injuries. Well, it became quite a mission for the Navy, and it started overburdening them with things that was going on. So they went to the state and said, hey, you got to do something. The University of Hawaii got together some professors. Mr. Frank Farm, which is our director, still is our director, in '82 put a chamber system down Koala Basin, and they started treating out of an old warehouse there right on the water's edge. And with that, they were treating between 80 to 120 divers a year of getting bent. And a lot of these divers at that time were fishing for a living, black coral divers, doing some deep dives. A lot of our Hawaiian divers, and we'll find that through time, never took any diving courses, so they just learned from, passed down from, dads, moms, cousins or something like that. So there were a lot of injuries because they didn't know any better. Now, diving's come a long way since then also. The physics of diving, how many dives, the step diving that people do now is a lot different. A lot of our Hawaiian divers we talk to just say, I do a 3-tank dive. At what depth? I don't know, just whatever I could get down to. So those are, kind of the mentality of where it went. After the chamber was down there, they were treating people, and then they said, hey, we got to step it up a little bit. So in 94, 95 timeframe, they opened here at Kuakini. They bought this new Perry chamber here, built it into the hospital right here, actually added the walls on. This old double lock here is from Koala Basin, and they modified it to adapt it into the Perry. So all of our chambers here are interlinked. So we can be running 3 treatments at one time at different depths, different people in there, and through it we can lock doctors, nurses, care providers in and out, because we use our transfer locks here as an elevator system, so we can run them down to different depths and take them in and out as we need to. Primarily for running our 2 big chambers back here in the back, they're ran from this console here. The other 2 on the side, there's 2 on this side here, which is that double lock, and then the transfer lock over here. They're ran by just the piping and the valves here on the side of the chamber. Definitely something we're looking at in the future, wanting to modify or update it, do modifications to bring it up so it's not so old, and to computerize it more. But at that time, this is how we just hand log it, just like we did the old deck logs. Write it in. We left surface in this time, got the bottom, did this, did that. So we keep track. So that's kind of the history of it. And since then, diving is the diving injuries have kind of dropped off, tailored back to where a couple years ago we were looking at only between 50 to 80 divers a year. Now it's even seemed less than that. We're down to kind of 40. And we wonder if it's the economy, not as many tourists coming over. A lot of the fish are fished out. A lot of the black coral divers are gone. We did notice that when Disneyland came in and they said, hey, we want a couple specialty tropical fish, we had bent divers at that time because they were going a little deeper, diving a little harder to get that $3,000 or whatever dollar. Don't take me. Any amount. No, any amount of a fish that they were saying, hey, I want this special fish that we'll give a dollar amount for. We actually had a couple injured divers from trying to get that fish. So that's where when people are living out of the water or living off of the their work in the water, they push themselves a little harder, and we do see that. There are those injuries that happen. But now it's down a little lower, so we call the dive lockers here, we kind of check around, are the diving numbers down, or there's just not as many divers. It seems like our generation from years ago are old enough, they're not getting in the water as much, a little bit more cautious, not as many fish. There's a lot of things, so we just kind of wonder what it is. But that doesn't keep us out of business here. We're not a fire department, we only just handle the fires. We also have wound healing. That's actually one of the biggest industries right now nationwide, even when chambers aren't right alongside the waterfront like we have here on the island, is that people with diabetic wounds, gangrenes, carbon monoxide poisonings, and others, that them are other things that we treat here in the chamber. We have patients come here on a daily basis because they're been prescribed oxygen therapy for 30 treatments. So once a day they'll come here Monday through Friday to do their 2-hour, 10-minute treatment of oxygen therapy. Almost like a massage type thing, but it's not a massage, it's in the chamber. But they'll come here, they'll do it, and then they'll go, and then the next day they come back again. So we do treat numerous patients. Now, like I said, with that, we treat a lot of them at the same time. Our chambers are large enough, we'll put 4 or 5 patients in at one time and leave the surface at the same time, treat them at the same protocol as we were talking about earlier. If they're on the same treatment, we'll put them in at the same time, treat them all at one time with one care provider in there tending to the 4 or 5 patients, and then they'll come out, we'll send them home, and another set will come in or whatever it might be. If we say, hey, we've got this set of 4 patients that are doing a depth of 47 feet, we can have another patient in the other chamber. As we said, we can run 3 treatments at one time. We can have them at a different depth, or we maybe want to isolate them due to their situation from the other patients that are in. So that's kind of the uniqueness. Any of our treatments, if anybody's familiar with chambers at all, this is a multi-place chamber because we can put more than one patient in. There's monoplace chambers, if you look up online, they're an acrylic tube set up to where a patient can go in. And therefore there's no care provider or anything in. They actually go into an acrylic tube, they shut the ends on it, and they pressurize. A lot of times on those, they'll pressurize with 100% oxygen. Now, of course, oxygen is not flammable, but it aids in fire combustion. And so what we do in our multi-place, we pressurize it with air, nice oxygen. One, it would be a lot of oxygen to do, for cost purposes. But the other is it lowers the risk of any fires in there. We monitor here our atmospheres inside the chamber to keep them below 24%. That minimizes the risk of a fire inside the chamber. That's why the oils from the street, from your shoes going in, hair oils, jewelry and other things. Now you say, well, why jewelry? Because of the sparking. If you start swinging your hand around in a seizure and it sparks, we don't want something to ignite. That's part of that fire triangle we will kind of touch on later. So we want to keep all that down to a very minimal chance of anything happening. And so that's kind of the multi-place, the monoplace. Like I said, again, it's pressurized with 100% O2, and they're in acrylic. They're by themselves. And ours is kind of unique because they're with a care provider. So as a situation might arise, we're able to tend to them at that time. Doctors can go in and administer medicine and when they're in a monoplace, they're in by themselves, so they're really hands-off until you can get them back to the surface. So it's kind of an interesting little setup. But a lot of that's in here. The other thing I included in here in our papers, and like I said, because it's training and however we want to work our training thing, is I did put our organizational chart. JAPSON is John A. Burns School of Medicine, so as you need acronyms or anything else. RCUH is our HR department, so that would be key in any of our training to make sure HR is involved, and that's it's labeled on one of these others, but it's the Research Corporation, University of Hawaii. You'll see, and then it goes down to our director, Frank Farm, our physicians, our doctors, and our nurses, the operators, the others. So we'll kind of go over some of those, and then the safety director down there too, which is very key for any of this that we start talking about with our training. Safety director and the physicians are the primary focus for anything that happens here in the chamber to make sure it remains safe. So that's just for information. I did include the command's vision, their mission, their goals, and a couple of their principles here, just so that as you start getting to any of this, you might key those into it because we're talking about this certain command. So just information as you start writing. You might need to make the extra 20, 30 words. You might be able to pull something out of there. So that's the only reason I put it in. Since we're doing our thing on training, and we're creating that training plan that we're looking at, I also put in a paper that we have in our policy and procedure manual, which is the Quality Improvement Program. So this is, if you look at here, some of this is in the book, like that PDCA. That plans, do, check, and action. That's exactly what's in the book. So it's kind of interesting that it kind of pulls out here. But this kind of goes. Quality is training. That's the only way you can get quality is repetition, training.